Good morning to one and all. Today we are going to start a new chapter in pathology that will be exclusively in hematology. So I hope you all know hematology is quite a important topic for exams. This specialty will not only overlap in your medicine, pediatrics. You will have a very significant contribution of questions in pathology, basically from the heme section also. Probably if you go back and check the latest edition of Robbins, the 9th edition, you will have 3 sections given in your Robbins. So what I have done in this section of hematology discussion is, we have classified all the hematology topics into 4 main subdivisions. So what are the 4 main subdivisions I am going to discuss on? The first is obviously the red cell disorders. Red cell disorders. Probably in this disorders we will cover all the topics, questions, what you will get in the exams from the various anemias and the hemoglobinopathies, and also from the various disorders of the red cells as such. So we'll cover these red cell disorders in detail, and I will also give a brief session on the various abnormal morphological changes in the peripheral smear. So this will be a one-shot session where we'll cover all the red cell disorders with an appropriate peripheral smears, bone marrow examination, and also we'll get the various tests done to assess the red cell diseases. So that's about the red cell disorders. Then we'll talk about the white cell diseases. Of course, you all know the white cell diseases. The very, very important topic in the white cell disorders is basically the neoplasms, especially the neoplasms. Most of you are having some issues or problems in the neoplastic white cell disorders. So we'll cover the neoplastic white cell disorders. When I say neoplastic white cell disorders, it includes lymphomas, leukemias, and the myeloid neoplasms such as your AMLs to your myeloproliferative disorders and the myelodysplastic syndrome. So we'll cover in detail about the entire white cell disorders also. My quest is to understand each and every disorder. Second thing, we should be familiar with the most pathognomic features of each topic. Then we should apply these topics what we have learned back in your questions. So that's the basic idea about the white cell disorders. Then we'll focus on the next very important topic, the bleeding and coagulation disorders. The bleeding and coagulation disorders. So this will be a very important topic. I want you to now pay close attention to the bleeding and coagulation disorders. The reason why, because the same topics can overlap with medicine and your pediatrics also. So in this bleeding and coagulation disorders, we'll talk about the platelet dysfunctions, then we'll talk about the coagulation factor disorders, then the various tests done to assess the bleeding and coagulation diseases. Then we'll talk about some of the acquired causes for the bleeding and the coagulopathies. So we'll discuss in detail about the bleeding and coagulation disorders. And the last topic which I have just got for you is the special topic that will be your transfusion medicine. Because this is where we are often also getting questions from the transfusion disorders. So transfusion medicine, especially the transfusion medicine is the best way to call this thing rather than transfusion disorders. So we'll talk about transfusion medicine in detail. Transfusion medicine. In transfusion medicine, we'll be talking about the various blood groupings, how the blood groupings are classified, and what is the basic workup we do when we go for blood transfusions, and how do we assess the compatibility of the donor and recipient. Then we'll try to understand the various blood components. Now the order of the day is like we have now gone from the whole blood transfusion to the blood cell component separation, and we are using specific component as components for transfusion practice. So we will understand each and every indications, what are the components and what are the uses, because we got a lot of questions from transfusion medicines. Believe me, there are a lot of questions in medicine, especially in the transfusion medicine topic, where we have got questions saying that what is the half-life of platelets and what is the shelf life of blood components of red cell disease, red cell components and platelet concentrates, or the cryoprecipitates. How do we assess the compatibility of a recipient donor for all these components? So all these questions are something we ask. We have been coming across in the exams. And also we are getting questions about some of the diseases like the febrile non-hemolytic transfusion reactions and TRALI, the transfusion related acute lung injuries. So we'll talk in detail about the transfusion medicine also. So in this section of hematology, I have 4 major the divisions. One is your red cell diseases, white cell diseases, bleeding and coagulation disorders, and your transfusion medicine. The red cell disorders. The red cell disorders, what are we going to cover in this red cell disorders? Red cell disorders. I will give you a brief tour on what are the things what I am going to share with you in the next couple of hours on red cell disorders, because red cell disorders are the most voluminous number of questions what we got in the exams. So red cell disorders, the main issues what I am going to discuss with you is trying to understand the normal values. First, I want you to first understand the normal values for the hemograms, especially the hemograms, normal values which you use for your hemograms. That is your complete blood count values. So get used to these normal values, because in the exams you may not get always the reference ranges or normal values right next to the patient values. So please get used to the normal values, because that's a very important point. I'll make it very simple. It's not going to be very tough. So let's learn some basic normal values. So always start your hematology from the normal structures in your bone marrows and also in the peripheral blood. So when I talk about red cell disorders, I'm going to focus mainly on the RBCs or erythrocytes. So my focus of interest is on the RBCs or erythrocytes. Second, what I'm going to focus next is, we'll focus on the peripheral smear examination. Now that's a very important question in the exam we get. Peripheral smear examination. Lot of questions about peripheral smear examination. People ask about acanthocytes. People ask about your codocytes or target cells. People ask about bite cells, Heinz bodies, Pappenheimer bodies. So we should know the various abnormal cells you can encounter in the peripheral smears. So the peripheral smear examination. So we'll learn about peripheral smear examination. I'll make it very easy. I will show you then and there the images so that you can easily correlate and even revise. And my humble request is, whenever you see this peripheral smears, I want you to pause and then see all the images, then keep revising now and then. At least I want you to see at least 4 to 5 times before you go for the exam, so that you will be comfortable. Minimum 4 to 5 times, and if you make it quite often, visits now and then back to these videos, that will be very good, because that's all you required for the exams. I have included all the images what you are going to get in the exams, so that you can see now and then in your peripheral smear examination session, right? So then, third thing what we are going to focus is on the various subtopics, something like immunohemolytic anemia, immunohemolytic anemias. In immunohemolytic anemias, we have sessions like warm agglutinin type, warm agglutinin type, cold agglutinin type, cold hemolysin type. So we'll learn all these things: cold hemolysin type, warm agglutinin type. So these are the 3 different types of immunohemolytic anemia we are going to discuss. So that's something we'll learn. Now what are the other things we are going to learn? Here we'll be mainly focusing on hereditary spherocytosis. Hereditary spherocytosis. That's a very important topic for the exam. we should be familiar with the basic pathogenesis. We should be familiar with the tests done in spherocytosis. What are the usual findings in your hereditary spherocytosis? That's something which they ask you in the exam. Second one, sickle cell anemia. Sickle cell anemia is a very important topic. We'll discuss in detail sickle cell anemia. Third thing which is very important is your thalassemia. Thalassemia. We'll discuss thalassemia in detail, both the beta thalassemia and alpha thalassemia. Alpha thalassemia. So that's something which I'll run down. Thalassemia. Then, what are the other things which I'll be focusing in for your exam? PNH. It's not a surprise. Paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. Very important topic. Then we'll have sessions from the topics, namely the G6PD deficiency. G6PD deficiency. That's a very, very important topic. G6PD deficiency. Then we'll be running down with the other very important topics. What are the other very important topics which you should know as far as anemia is concerned? The number one is your iron deficiency anemia. Iron deficiency anemia. So, iron deficiency anemia. Then, megaloblastic anemia. Megaloblastic anemia. We'll talk in detail about the B12, that's a cobalamin deficiency, and your folate deficiency. Folate deficiency. So that's something I'll focus. Iron deficiency, megaloblastic anemia. Then, very importantly, the other anemia which you should know for exam, because often you get in the choices, is anemia of chronic disease. Anemia of chronic diseases. Anemia of chronic diseases. So that's something which I want you to go through for the exams. And the last thing, there are a few unusual anemias which you may come across. Myelophthisic anemia. Myelophthisic anemia. Myelophthisic anemia. So I think our job will be done if you are able to cover all these things for the exams. So when you have red cell diseases, you should be comfortable in answering majority of the topics what you have done. I'll add here and there some valuable points for your exams, because these are the points which will help you, guide you, answer your questions efficiently in the exam. So my quest in your red cell disorders will be understanding the first thing, normal things. What are the normal values in the blood, bone marrow, and the various indices which we use to assess any patients who have an underlying hematologic disease. Then understanding the peripheral smear, because peripheral smear is something which you get in the exam, so I've got all the bunch of pictures for you. Then the various diseases I'm going to run down. So get a panoramic view. This is a panoramic view what we are going to run down for the exams. Now we'll understand where all these red cells arise from. They all arise from the bone marrow, especially the primitive bone marrow cell called pluripotent hematopoietic stem cell. So let's understand, this is the pluripotent hematopoietic stem cells. So that's something I want you to learn. Pluripotent hematopoietic stem cells. So that will be now giving rise to the various committed lineages of two major divisions. That's what I want you to understand. Any stem cell, this is the pluripotent hematopoietic stem cells, will give rise to two major headings. The two major divisions what you get in the pluripotent hematopoietic stem cell is, one, we have these myeloid lineage. Then we have the lymphoid lineage. That's something which you should know for exams. Myeloid, lymphoid. Now, please understand that myeloid lineage is a lineage which gives rise to various sub cells or the mature differentiated cells. The myeloid lineage will give rise to the cells, namely megakaryocytes. Megakaryocytes are the one which gives rise to the platelets. Then we'll focus on the next thing. The myeloid lineages are the one which gives rise to the monoblast. Monoblasts are the ones which gives rise to the monocytes. Then myeloid lineage also gives rise to the various granulocytes. What are the granulocytes? You all know, are familiar with. The granulocytes are the neutrophils, eosinophils, basophils. So myeloid lineage also gives rise to the granulocyte family. So this is basically coming from the granulocytic precursors. Granulocytic precursors in the marrow. The granulocytic precursors are the ones which we'll see in the marrow, which gives rise to the mature cells like neutrophils, eosinophils, basophils. Now we'll focus on our importance. Basically, you're interested in the erythrocytes. Erythrocytes also come from the myeloid lineage. So, myeloid lineage is the one gives rise to the erythrocytes, megakaryocytes, monocytes, giving rise to granulocytes. Then last one, it also gives rise to the mast cells. So, myeloid lineage, if you just cover, C gives rise to number 1 erythrocytes, number 2 platelets, number 3 monocytes, number 4 granulocytes, namely the neutrophils, eosinophils, basophils, and number 5 mast cells. Lymphoid lineage, on the other hand, can give rise to the two main subdivisions, namely the T cells and your NK cells. NK cell is natural killer cells. Then the other cell is B cells, B lymphocytes. So the lymphoid lineage are committed to two families. The first family gives rise to the first lineage gives rise to the T lymphocytes, T mature lymphocytes and natural killer cells. The second subdivision gives rise to the B lymphocytes, the mature B lymphocytes, what we get to see in the bone marrows and also in the lymph nodes and the various places. So we'll talk in detail. So the whole quest is understanding all these things comes from the stem cell. This is called the stem cell. So once you know these are the major cells which are coming from the pluripotent hematopoietic stem cells, it will be easy for us to go and further understand the subtopics. Okay, so now we will focus on stages. So that's very important. What are the stages of erythropoiesis? So probably if you just see what are the stages of erythropoiesis, we can just classify all the stages of erythropoiesis into subdivisions, stages. So what are the stages? If you just happen to see, I mentioned it starts from your pluripotent hematopoietic stem cells. Now that will give rise to the first committed cell line. The first committed cell line is your colony forming unit of erythroid lineage. Erythroid lineage, colony forming unit of erythroid lineage. So it's also known as CFE. This is the earliest stage. That's the earliest primitive cell which you get to see in your erythropoiesis. The next stage is your proerythroblast. Proerythroblast. So that's the earliest. That's your earliest cell in the erythroid family, proerythroblast. The proerythroblast will give rise to the subsequent cells. What are the subsequent cells? The first cell is your basophil. Basophil erythroblast, basophil erythroblast, polychromatophilic erythroblast, polychromatophilic erythroblast, then orthochromatic erythroblast, orthochromatic or chromatophilic, orthochromatic or orthochromatophilic. So you can just say the same thing, orthochromatic or orthochromatophilic erythroblast. So if you see, the proerythroblast is the one gives rise to basophil erythroblast, polychromatophilic erythroblast, orthochromatophilic erythroblast. In fact, some of the textbooks even say they are known as early, intermediate and late normoblasts. That's all. It's easy now. So once we have the blast, that's your proerythroblast, will give rise to basophil erythroblast, then subsequently polychromatophilic erythroblast, orthochromatophilic erythroblast. Finally, it will end up in reticulocytes. Reticulocyte is the penultimate step in your erythroid production. Finally, it gives rise to the erythrocytes. The final step is your erythrocytes. So these are the stages of erythropoiesis. So if someone asks the stages of erythropoiesis, I think we are done. That's all is the stages what we have to know for exams. The pluripotent hematopoietic stem cells will give rise to the colony forming unit of erythroid lineage, which will give rise to the earliest cell known as proerythroblast, basophilic erythroblast, polychromatophilic erythroblast, orthochromatophilic erythroblast, reticulocytes, and also the final mature cell known as erythrocytes. Now let's focus on the places of erythropoiesis. We have learned about stages, so now we'll look on the sites of erythropoiesis. Sites. Where is the early sites of erythropoiesis? Where is the early sites of erythropoiesis? This is, we'll have to travel back during the period of embryogenesis. So if you go back during the stage of embryogenesis, the earliest place for the embryogenesis is in the yolk sac. So which means yolk sac is the earliest place for embryogenesis. So followed by the haploid stage where you will start seeing from the third day onwards, you find yolk sac is a main place for, yolk sac is a place for the hematopoiesis. Yolk sac is a place for hematopoiesis. Whereover haploid stage, the haploid stage will be the place for hematopoiesis, where you will start seeing the hematopoiesis in liver, spleen. That's your second phase of your hematopoiesis. This will happen by around third month. This will happen around third month of your embryogenesis, the haploid stage. Then finally you will have the last stage called myeloid stage. Myeloid stage is where the entire hematopoiesis happens back in your bone marrow. So that's the place where you get the hematopoiesis. So the bone marrow That means all the bones in your body, by the time when the fetus completely formed and is about to go into the third trimester. So during the third trimester, so that's a very, very important point. Third trimester, the bones will be the major site of hematopoiesis than your liver, spleen and your lymph nodes. So basically the yolk sac is in the early phase, the third day, fourth day, the first few weeks. Then liver will be the primary site of hematopoiesis by around third month, and then by around third trimester you have a myeloid stage. So if you remember the rule of 3, third day yolk sac, 3 months your hepatoid stage, then third trimester your bone marrow, it will be easy. So that's all you can remember for the sites of hematopoiesis. First in the yolk sac, followed by the liver, followed by the bone marrow. And this hematopoiesis happens in all the bones, both flat bones, long bones in your body. But as the child grows by around adolescence, the flat bones and smaller bones will give rise to only the few the hip bones and also the long axial bones for bone marrow rather than all the bones in the body. So that's how the entire the hematopoiesis happens during the adult span or adult life. Okay. Now we will focus on the normal values, what you should know for exams. This is something which I want you to by heart. Like there is no other way. We should know the normal values before we start interpreting any hematological cases. So I will run down very quickly some of the very important points, the normal values. Say for example, your questions will be hemoglobin values. Hemoglobin values. That's something which will differ for the men and women. So keep in mind, there is a subtle variation of the values, hematological values for men and women. So hemoglobin is measured in grams per deciliter. Grams per deciliter. So if you look into the normal values, I wanted to learn the upper limits because like all for the men and women, I always look when I see a hemoglobin reports the value of the patient's hemoglobin with the reference range of upper limit or reference range of the limits of your men and women. So if I have men, I often keep little higher value. So this will be the higher value between 13.5 to 17, whereas for women it will be somewhere around like a 12. 12 will be the lowest limit what you should know, and it may go up to 15. So that's the normal value of the hemoglobin in grams per deciliter. Then we'll go for hematocrit. Hematocrit is always measured in percentage. Hematocrit is measured in percentage. So I wanted to now understand the hematocrit value is somewhere between, for men it will be around 39 to 49, whereas for women it is 33 to 43. 33 to 43. So that's where is a PCV value, the hematocrit value, packed cell volume, the hematocrit value percentage starts 39 to 49, 33 to 43. Then I wanted to now understand the red cell value. Red cell value. So basically the red cell count. So basically the red cell count. What I am going to give you. So the red cell count is something I wanted to learn. For men, it will be around 4.3 to 5.7 or 6. So 5.6 or 5.7. So 4.3 to 5.6 into 10 to the power of 6 per microliter. 6 per microliter. So this is the value which I want you to remember for men. It is a value for men. So the same thing applies for the women also, but little lower range, 3.0 to 5.0, 10 to the power of 6 per microliter. So that's a basic value for the red cell count, 4.3 to 5.7 or 3 to 5.0. So that's your values given for the men and women red cell count. Now we'll go on for the retic count. That's a very important question we get in the exam. Reticulocyte count. Reticulocyte count. That's something every examiner is assessing. So again, this is measured in percentage. This is measured in percentage, and we don't have any separate values for men and women. The reticulocyte percentage is basically the around 0.5 to 1.5. Now usually what I remember is always retic count is normally lesser than 2, more than 0.5. So that's the basic idea, lesser than 2. That means 0.5 to 1.5 is a reference range. What does the reticulocyte count indicate? Reticulocyte count indicates the normal proliferating capacity of the marrow. The normal proliferating capacity of the marrow. So that's your retic count, right? That is your retic count. Now we will understand the red cell indices. The red cell indices. Red cell indices. That's the very, very important numbers or values you should know with the units and the normal values. Now what are the red cell indices? What we have to know for exams. I will just quickly run down some of the values. The first thing is mean corpuscular volume. Mean corpuscular volume. Mean corpuscular volume. So what is MCV means? MCV means average volume of a given red cell in a patient. So average volume of a given red cell in a patient. So usually the MCV is measured in femtoliters. Femtoliters. Usually measured in femtoliters, and the value is basically between 80 to 96 femtoliters. 80 to 96 femtoliters. So mean corpuscular volume measured in femtoliters. Now we'll go for the next one, mean corpuscular hemoglobin. Mean corpuscular hemoglobin. Hemoglobin. Now what is the mean corpuscular hemoglobin? It means average content of a hemoglobin in a given red cell. Average content of a hemoglobin in a given red cell. So usually this is measured in picograms. So I want you to remember the unit what we use for this is picograms, and the normal range is between 27 to 33 picograms. So keep in mind MCH, mean corpuscular hemoglobin, means average. So if I take a given red cell, what is my average content of a hemoglobin? If I have 100 RBCs in a given blood sample, what is the average value of the hemoglobin in a given red cell of a patient? That's your MCH measured in picograms, 27 to 33. Now we'll go for a little further unit which you should know for exam, MCHC. That's even a better index. Mean corpuscular hemoglobin concentration. Mean corpuscular hemoglobin concentration. Now that's measured in percentage. So keep in mind that can be measured in percentage, or you can even say grams per deciliter. Grams per deciliter. Grams per deciliter. So that will be around 33 to 37 grams per deciliter. Grams per deciliter. Now usually I remember like this. Keep 27 to 33 for MCH. From 33, that's your upper limit. So lower limit of your MCHC, 33 to 37. So 27 to 33 MCH, 33 to 37 is your MCH, the normal value. Now we will go for the next very important value, the RDW. RDW. What do you mean by RDW? The red cell distribution width. Red cell distribution width. Now the red cell distribution width, usually the normal range of a distribution width is 11.5 to 14.5. 11.5 to 14.5. 11.5 to 14.5 is a normal red cell distribution width. So I think we are now familiar with all the red cell indices. MCV, the average volume of given red cell, it is measured in femtoliters, 8296. Average concentration of hemoglobin in a given red cell. So the mean corpuscular concentration is your average concentration of a hemoglobin in a given packed volume of red cells. That's something which I wanted to know for exams. So this is something, how does this different from this different? This is MCH and from MCHC. Now that's a very important question. MCH is your average concentration of a hemoglobin in a given red cell. Suppose I have 100 RBCs, and out of the 100 RBCs, what is the average concentration of the hemoglobin is MCH. Now if I want to compare my hemoglobin concentration with the patient's blood volume, then that might be little different. Why? Because suppose when the patient has a hemodilution, then what will happen is you may have an artificial decrease in the hemoglobin, or you may have a hemoconcentration, you may have a relative increase in the hemoglobin. So we have to just adjust the values and give you an appropriate answer for the hemoglobin concentration. Then the answer will be MCHC. MCHC will give you a better value of hemoglobin concentration by giving you a measure of average concentration of hemoglobin in a given packed volume of RBCs. When you know the packed RBC value and you compare with the concentration of the hemoglobin, then that will be the ideal way, because here you are trying to consolidate the point of hemoglobin concentration in relation to the packed cell volume than the volume of RBCs. So that way you are not having to have any false positive or false negative up and down values. So mean corpuscular hemoglobin concentration means average concentration of the hemoglobin in a given packed volume of RBCs, measured in grams per deciliter percentage, and the range is 33 to 37 grams per deciliter. Now we have got one more things to clarify. What are the normal lifespan of the RBCs, the normal lifespan of the platelets, normal lifespan of your white cells? So we will try to clarify all these points. The normal lifespan of we'll start with the first thing. The normal lifespan of your first thing is your erythrocytes. The normal lifespan of erythrocytes, most of you know the answer is on an average 120 days. 120 days. So that's the normal lifespan of the erythrocytes, 120 days. Now for the neonates, they can just vary between your 60 to 90 days. So this is for an adult. Suppose if the question is for the neonates, the normal lifespan of erythrocytes is between 60 to 90 days for the neonates. Now we will go for what is the normal lifespan of your granulocytes. Granulocytes means the leukocytes. What is the normal lifespan of the leukocytes? Normally the lifespan of leukocytes is around 13 to 20 days. That's something, an MCQ. 13 to 20 days. That's an MCQ. Now what is the lifespan of platelets? That's a very important question. What is the normal lifespan of the platelets? The answer is 8 to 10 days. 8 to 10 days. So that's the usual lifespan of erythrocytes, leukocytes and platelets. We'll now shift our gear into bone marrow. Bone marrow will learn some normal values, because you may get some questions in your exams. What is the normal values of the bone marrow? Normally in a bone marrow, you all know, suppose if I'm going to take a bone marrow and see a bone marrow is made up of two things. One, fat, adipose tissue. And then it will have hematopoietic elements. Hematopoietic elements. So any bone marrow is a mixture of these two things. One is your fat, the other one is your cell. Fat and cell. Fat is your adipose tissue, cell is your hematopoietic elements. The hematopoietic elements include the erythroid cells, myeloid cells, including megakaryocytes. So any hematopoietic elements, it includes three cell lines: the erythrocytes, the erythroid precursors, then myeloid precursors, and then megakaryocytes. So any pathologist who sees under the microscopes of a bone marrow will come across these three things: erythroid cells, myeloid cells and megakaryocytes. So these are three things he will be looking for. That's why we often say hematopoiesis is tri-lineage hematopoiesis. Tri-lineage means we have erythroid lineage, myeloid lineage and megakaryocytes. So we already know that erythroid lineage will give rise to RBCs. Myeloid lineage will give rise to all the other things except the erythrocytes. You have to say granulocytes. Granulocytes include neutrophils, eosinophils, basophils, then monocytes, then megakaryocytes will give rise to platelets. So that's all in the peripheral blood. But in the marrow, we have erythroid, myeloid, megakaryocytes. Now we'll understand what is a normal ratio. Normal ratio. So the question will be in the exam, what is the normal ratio of the fat to cell? Normal ratio of fat to cell. Suppose if we have an adult, say for example 40 years or 50 years, in a middle-aged population, if I take a bone marrow and see, the marrow will be 50% fat, 50%. Generally, suppose in the exams, if you get a question, in an adult, the ratio of fat to cell, it is mainly 50-50. 50% fat, 50% cells. That is when you talk about an average adult. Suppose if you have a patient saying 25 years, 30 years, when compared to 65 years, then I can't use the same logic saying 50-50 for both the young adult and also an older adult. So I have a little formula for you. It's very easy. All you have to do is take the percentage of marrow into 100%. Suppose if I say the marrow, what is the average, what is the marrow size of a let's say 65-year-old individual. 65-year adult. Very simple. All you have to do is, for a 65-year adult, all you have to do is take the marrow as 100%, deduct his age 65 years, and then you find out 35%. So his cells will be only 35% in a 65-year-old adult. So this is the percentage of the marrow cells in an age of 65-year-old. Suppose if the question is 35 years. It's very simple. It's an opposite where you have to just say 100 minus 35. Usually you get around 65. So 100 minus the age of the patient is the percentage of the bone marrow in a given individual. So that's your total total number of cell percentage, the expected cell percentage in a given adult. So if you know this first point, it's easy. I think we have done with the first point. What is a normal ratio of your fat and cells? Now the second question in the exam is, what is a normal ME ratio? Normal ME ratio. What is normal ME ratio? Normal ME means myeloid erythroid. Myeloid erythroid. What is the normal range of myeloid erythroid ratio? I want you to now understand that your myeloid erythroid, who is going to be the dominant is myeloid. Myeloid is going to be the dominant. So the normal expected myeloid ratio is 2:1 to 7:1. This is the expected range of ME ratio. If someone asks what is the normal ME ratio, even if you say 3:1, 4:1, I will be happy. Why? Because that's fitting into the normal range. But in medicine, especially in hematology, never say one value, because that is not reflection of your, that's not reflecting your understanding of the range of the cells, what you can have, what is the range of values you can have in the hematology. So always express in ranges. When I say ME ratio, the normal expected ME ratio is 2:1 to 7:1. So majority of the time, my dominant population is your myeloid cells. Myeloid cells. The normal ratio is 2:1. 2:1 is a normal expected ratio. Now, suppose if you are assessing only myeloid erythroid, how about megakaryocytes? Can you have any value for megakaryocytes? Yes, I have one simple formula. The megakaryocytes can be assessed for its adequacy. Megakaryocytes can also be assessed. How do you assess megakaryocytes? All you have to say is, if you take one high power field, in a single high power field, you should have 2 to 5 megakaryocytes. If you have 2 to 5 megakaryocytes in a single high power field, that's the expected normal number of megakaryocytes. So that's how we say megakaryocytes are appearing normal and also adequate in number. When I say adequate means I am expecting around 2 to 5 megs per one single high power field in the bone marrow examination. So bone marrow, we do aspiration and biopsy to assess your adequacy. So we have ratio of fat to cells, and then normal ME ratio, and then megakaryocytes. Okay, now we'll go on to the next normal value. That's the leukocytes. Leukocytes. Now leukocytes, as you all know, roughly ranges in the value between 4,000 to 11,000. 4,000 to 11,000 cells per cubic millimeter. So that's your 4,000 to 11,000 value. Now if you look into these 4,000 to 11,000 cells per cubic millimeter, so if you look into it, the differential count, what is the differential count of the leukocytes? Differential count of the leukocytes. We all have, namely, neutrophils. We have the eosinophils, then basophils, then lymphocytes, then we have the blast, the band forms. Normally blast, you will not be able to see that. This will be in the band forms. Right. So the normal range of the neutrophil in any given peripheral smear ranges between 45 to 70%. 45 to 70%. And your eosinophils roughly ranges between 0 to 0 to, even it might go up to 6%. The 6% is the cutoff value for the eosinophils. Now we will go for the basophils. The basophils will be around 0 to 3%, 0 to 3%, 0 to 3%. And your lymphocytes, how much your lymphocytes can move up is somewhere around 15 to around 40%. Lymphocytes can just move up to 15 to 40%, and your band forms can move up to maximum of 5%. Band forms means you have the metamyelocytes and the unsegmented or the neutrophils when they are arranged in band forms, where you find the band like structures like this in a given leukocytes. So where usually you see the neutrophils will be like this, where in lobes, minimum 3 nuclear lobes. It might be going up to 4, it might be 5, but not 6. So the number of neutrophil lobes is mainly 3. Sometimes you have 4, very rarely 5. The number of neutrophils in a given peripheral smear should not exceed 5%, beyond 5% of your 5 lobes, which means in any given patient, the percentage of 5 lobe containing neutrophil should not exceed 5%. Even if you have single neutrophil with the 6 nuclear lobes, it is called as hypersegmented neutrophils. Hypersegmented neutrophil is something a very good point for you to raise a differential of megaloblastic anemia. So that's one of the earliest sign for megaloblastic anemia is hypersegmented neutrophils. So band forms means it's a neutrophil precursor which is not having the lobations. It is something arranged in a band forms. So that's your band percentage. Right? So the basophils, eosinophils, neutrophils, you should know the rough range. Lymphocytes, it might just fluctuate up to 15 to 40%, and then your basophils, the band forms can move up to 5%. Now we'll start understanding the hemoglobins as such. Now normally the hemoglobin, I hope you all know, hemoglobin is made up of 2 different things, basically the heme and the globin. Heme and the globin part. Now basically this hemoglobin is produced from the genes called as the genes which are manufacturing the hemoglobin are from the 2 different things. So basically if I am going to have hemoglobin, the hemoglobin is made up of alpha 2 and your beta 2. So this is the genotype version of your hemoglobin. So if I say an adult hemoglobin, this adult hemoglobin genotype is alpha 2 beta 2. Now this is the normal genotype of hemoglobin adult type. Now we also have, this is the hemoglobin A1. There is something called hemoglobin A2. This is hemoglobin A1, hemoglobin A2. Hemoglobin A2 will have a genotype of alpha 2 delta 2. Then we also have hemoglobin F. So hemoglobin F is alpha 2 gamma 2. So I think we have learned 3 types of hemoglobins. Hemoglobin A1 adult type, hemoglobin A2 alpha 2 delta 2, hemoglobin F alpha 2 gamma 2, and then there are few more hemoglobins which we will be discussing now. Hemoglobin S, hemoglobin C. Now they don't have any changeover from the alpha and beta chains, but they all have one thing in common. The alpha and beta chains, they have a mutation in the beta chain. they all have what do you call it as mutation in the beta chain, especially in the mutation in the beta chain. Where do you have a mutation in the beta chain? Especially the mutation is in the 6th position. 6th position, where you have valine is getting substituted for glutamic acid. So basically the glutamic acid is getting substituted into valine at the 6th position of beta chain. So at the 6th position of beta chain, there is a point mutation where glutamic acid becomes substituted into valine. That's your hemoglobin. Yes. What about the hemoglobin C? Here there is a mutation in the same beta chain, the same position, 6th position. Here it is mainly glutamic acid is getting shifted into lysine. Glutamic acid is getting shifted into lysine. So I think we have learned the various subtypes of hemoglobin A1, alpha to beta 2, alpha 1 is alpha to beta 2. In fact, it roughly constitutes up to 95%. In fact, if you look into the normal percentage, what we can have, 95 to 99% is basically your hemoglobin A1. Your hemoglobin A2 value roughly around 2 to maximum 4%. That's all. The normal range is around 2 to 4%. Anything beyond 4% is definitely abnormal. So keep a value of 2.5 plus or minus 0.3 for your hemoglobin A2. Anything beyond 4, definitely an elevated level of hemoglobin A2. Hemoglobin F, it's a fetal type of hemoglobin. It's found only during the neonates. The hemoglobin F, usually in adults, will be less than 1%. Hemoglobin F, alpha 2, gamma 2. And hemoglobin S, hemoglobin C. Now we'll add one more point. Hemoglobin alpha and beta chains. Where the alpha chains, what is the alpha chain gene? What is the chromosome locus for the alpha chain gene? What is the chromosome locus for the beta chain gene or the chromosome? This is the chromosome locus 16. This chromosome locus is 11. So please understand, this is an MCQ. The beta chains are produced from the gene which is residing in the chromosome number 11. Alpha chain is produced from the gene residing in the chromosome number 16.